Emergency surgery, as you say, is something of a hot potato. And I guess over the last 4 or 5 years in the UK, it's come very much to the fore based on poor outcomes, the publication of those outcomes by Dr. Foster and then by the BBC, and the production of several reports by ASGBI and colleges that have laid out ways in which you can address that. This is one of the scientific articles from what's called the Emergency Laparotomy Network, that was a series of enthusiasts that went around 37 hospitals gathering data. And here are the results, which make some interesting reading. A 15% mortality for laparotomy. Bear in mind, these are hospitals that want to contribute data, not those that have to contribute data. That mortality rising to 25% in the elderly. And the thing that interested the government most of all was the wide variation. For example, this picture from Dr. Foster for my own northwest of England area is typical of those you can just pull off the web. And this shows a threefold variation in survival for an operation as easy as small bowel resection for obstruction, one of the things we think is easier rather than harder. The 100 is the average. Of course, that doesn't tell you if it's the average for League Division 1 or the average for League Division 4, and that's another question. Some of the problems facing us in emergency surgery, without going into the whole background, are shown here. Patient numbers increasing with the age profile, lack of resources in our country of theatre, of diagnostic and interventional radiology, of critical care, of the arrangement of beds, lack of the surgical team we used to have, and changes in training. Subspecialisation in elective surgery has been fantastically successful in the last 10 or 15 years. Translating that into emergency care is a lot harder. Rationalisation of hospitals, ongoing further hot potato, and outcomes, as we've hinted at. Relating that to Europe shows up some interesting highlights, and that'll be one of the challenges of having any trans-European thoughts. This is a EU document, as you can imagine from the title, and it shows some interesting things. Here's the number of practicing doctors per 1,000 population on the left in the European countries. I don't know if we can dim the lights at the front, guys. And on the right, it shows the percentage change. I've highlighted the UK. Sorry for those of you who are not from the UK, but for the audience there, you see the UK, and you see that's despite a huge increase. We're one of the biggest increasers in doctors. We're still away down here in terms of doctor numbers. Here's health expenditure per capita, despite being one of the wealthier countries, despite having a huge input of health since Gordon Brown in 2002 or whenever it was. You can see we're just creeping into the top third. And what have others said about urgent surgery in the UK? Well, ASGBI has a history of asking eminent overseas surgeons to come and comment on EGS. Here's two. Professor Schroeder 3 years ago thought we should have more staff and worked the European Working Time Directive, quoting that surgical care is safer when you're not tired. And Ari Lepaniemi from Finland a couple of years ago commented on our lack of emergency surgery structure, a lack of leadership and a lack of priority, and wondered if there was a conflict between elective specialist care and emergency care. Looking at contemporary outcomes in emergency laparotomy, this is a paper from last year from Emma Barrow, shows we do about between 30 and 50,000 of these a year, 15% mortality, but that includes 8% for expedited cases, which covers a wide range of semi-urgent cases, but up to 25% for immediate laparotomies by NCPOD class, i.e. within 2 or 3 hours. Thank you. 21% for small bowel resection, 24% for incarcerated hernia. You contrast that with an anterior resection at 5% and a right hemicolectomy at 1%, and you wonder why all the emphasis is on those. And Barrow's conclusion was that there's a strong case for regarding all emergency laparotomies as being of sufficiently high risk to warrant mandatory consultant involvement and transfer to critical care. Well, how do we actually fare on that? Here's the ELN data. This shows consultant surgeon in red and consultant anaesthetist presence in blue, and mortality in black at different times of surgery in those 40 hospitals. You see as the patients get sicker, the consultant presence gets less. Where do they go? Well, you can see that in the UK, still over a third of patients still go to the ward, despite having a mortality on average of 15%, which seems a wee bit strange. And when you look at the predicted mortality, there's almost no laparotomy that you'd predict an outcome of less than 10% for. A femoral hernia in a young fit patient with a bowel resection, I'm not sure I've ever seen a femoral hernia in a young fit patient, but if you did, that would come in about 9%. What are the cases? Well, most of them, or almost most of them, are colorectal. If you look at them, colorectal 44%, general 42%, of which half are small bowel, so you can say that's colorectal. A fifth are for complications of elective surgery. That reflects the proportion of surgeons in our country who are colorectal surgeons, and just the beginning of some evidence maybe that the outcomes of colorectal cases are better when done by colorectal surgeons. That's very weak data from how it was set up, but there are one or two bits of weak data there, and it'll be interesting to see what the National Laparotomy Audit says, because it will look at that slightly more robustly. But maybe something on the argument for subspecialization being extended rather than curtailed, although it's a complex call. So to begin a summary, what can you see? We need to have consultants there for major surgery. They need to go to critical care, and subspecialization may have some benefits to bring. What about the management of elective complications? Almudaris et al. Looked at 150,000 colorectal cancer patients in England, and they found a significant difference in the way in which different units were successful in salvaging those patients. Major complications happen at the same rate, but there's almost a threefold difference in survivability of major complications depending on where you are. One other nubbin that's there on the website that comes out when you look is how many hours are on-take consultants expected to be on site in London's hospitals. This was part of the London Health Review, and that showed that through the week, it was on average 7 or 8 hours. At the weekend, the average might be the same, but the range included 0. So it's obviously not uniform care for people having complications out of hours. So questions to be asked there. And that might lead you to conclude that specialist care requires daily senior review of all the major elective cases if you're going to make timely diagnosis of complications. One thing we have in the UK now is a national laparotomy audit. It's been going for just over a year, first of all as organisational audit, and for the last 3 months as individual patient data. And we'll talk about this more on Friday. The organisational audit, 176 acute trusts, 191 in all, shows there are still problems with the key resources. Not all have a EGS theatre at all times. There's still non-specialist ICU cover, and there's still a significant problem with radiology that we'll touch on. 5 years ago, only 1 in 5 had a comprehensive interventional radiology service. I can tell you that's gone up to 1 in 3 in the last 5 years, but 2 out of 3 still have to wait for interventional radiology till Monday morning, when it's the recognised treatment for quite a fair number of conditions. That's even though we know that safer hospitals have more ICU beds and more CT scanners, and that comes from Simmons et al., who again looked at several 100,000 acute admissions from the National Statistics of Hospital Discharges, published in the BJS this year. What about the spread of CT scanners across Europe? Well, here you see these are some of the things we need imaging for in emergency surgery, from diagnostic ultrasound to get the gallbladders moving, down to interventional radiology. You can see that the UK is way down here, somewhat near the bottom of the league table of numbers of CT scanners, even though we know it correlates with outcome. One concept that we've begun to think about in the UK is what are the components of emergency surgery? Without a surgical team, it's quite hard to do it all yourself. So maybe it's constructive to look at what the bits are and think, well, in my hospital with that number of patients, do we need to divide that 2 ways, or can we split it this way or that way, or what? And here are some of the components that you all know. The ones we have particular problems with are new patients and having a hot gallbladder pathway because we don't have one for some reason. So let's think about new patients, the new patients turning up on take. The population's gone up in the UK by 10% in the last 10 years. Older people present more often acutely, and that will bring a 3% increase per annum. They tend to be frail and complex. Patient expectations have changed. The senior and junior doctors are often on shifts, so that brings all sorts of changes, and we're labouring along trying to play football by 1930s rules when the game has changed a lot. What's the pattern of doctors like in the UK then? Well, here you see that we have relatively few generalists compared to the number of specialists. You'll see where this is going in a moment. We have relatively few hospital beds compared to the others. And we have quite a long length of stay. So if you've no generalists to do your A&E work in your primary care, and you've no beds, and you've a long length of stay, you can see that your beds are going to be pretty full. And you're going to incur a lot of pressure because you're not dealing with the problem the right way. What do other countries do? Well, asking around numerous colleagues in a fair number of countries, those ones in particular, many have better A&E or primary care, but they've got more doctors doing it. Almost none subspecialise as early as we do, and no one seems to be trying as hard to subspecialise and have consultant input at the same time on the background of almost no bed or relatively few beds. It's putting a lot of pressure on our systems. So, although we talk about rearranging the deck chairs on the Titanic, it doesn't really make sense when they're all full if a third of the patients in the deck chairs don't need to be there at all. And having a surgical triage unit, there are maybe 8 units in the country that have reported reducing acute admissions by a third by having a surgical triage unit with a senior doctor on the front door, which is a big difference. Separate area with trolleys, predicated imaging slots, a parallel hot clinic to hive people off into, and appropriate staffing to run that can really make a big difference in the number of people coming in. For example, from Blackburn here, over a period of time, this came from Rob Watson, this data, they were able to treat 25% in the hot clinic, saved £750,000, and had a parallel hot gallbladder service where they doubled the number done and have the conversion rate, to pick a few of the stats out. So the surgical triage unit controls your access, lightens your inpatient load, and parallel steps forward in radiology, hot clinic and gallbladder service, day case abscess service can all follow from that. So adding to our wish list here, you might want to have a consultant-led surgical triage unit in every acute hospital, providing ambulatory care for 30% and a defined hot gallbladder service for the other 30% of patients who come in who have acute biliary disease. How's that change going to happen? Well, it needs leadership, and there are 2 ways to do that. One is by a clinical lead for emergency surgery, and the other is by an emergency general surgeon, which is a slightly contentious area, as we've just heard. But if you just leave focusing on emergency surgery to on-call guy of the day, you're going to sell yourself short. What about emergency general surgeons? Half are young, half are old. They've all been relatively recently appointed by and large. They undertake a fair amount of a range of surgery. Most have an elective practice as well, half of which is hernias, lap choles, and day case. But you see that of those that have emergency surgeons, most of them are able to have hot clinics, dedicated imaging, and a surgical triage unit. So moving your service forward works a lot better if you have somebody dedicated to do it. What about the future, though? Well, that's where we may run into problems in the UK. When we surveyed our surgical trainees, pure emergency surgery was the least popular option because it's perceived as a second-class specialty by them. They want to be super specialists, but many of them think that a mix of more emergency surgery in their early days while they learn their complex work was acceptable, and that may well be the way to go. When we looked at the experience of trainees coming out of the training program, we saw that the bottom quartile were pretty light on trauma, laparotomy for acute abdomen, and Hartmann's procedure. And not surprisingly, when you survey consultants, now this is survey data from earlier this year, you see that the proportion of consultants who feel ready for doing the take on appointment has steadily fallen over the years. Consultants of my vintage, 80% of them felt ready to do the take-on appointment. 5 to 10 years ago, it was down at 70%. Those appointed between 2 and 5 years ago are down at 60%. So there's a skill or there's a confidence issue there that we need to somehow think about. So one recommendation would be that combining future delivery of emergency surgery with subspecialist elective surgery may be best met by new consultants doing an increased share of emergency surgery while they further develop their complex skills within a consultant job. On the other hand, those who want to do emergency surgery as a career should be valued, treasured, and stuck on a pedestal and looked after. So here's our list here. We'll add that to the bottom there. And in conclusion, just to say, Mr. Chairman, that underpinning all this, a change of mindset of not seeing emergency surgery as an inconvenient add-on to our real work is essential. That duty must be reasonable and manageable, and with an increased number of patients, the lack of team, relatively lightly trained junior doctors, we need to change the way we do it. It needs enough resource, and it has components which can usefully be defined. What can we bring to Europe? Well, you know the British general thoughts on Europe, but in fact what we do have is we already have a national audit on emergency surgery that could be rolled out. We could collaborate to show comparisons between countries and how different ways of handling the same things may work better for each other, and we could establish joint standards of care which we could learn from each other. Thanks very much.